Picture this. It's a busy Monday morning at the clinic. The waiting room is absolutely packed. And it seems like almost everyone has the exact same complaint, a cough. So is it just a cold, the flu, something more serious, like pneumonia? For the doctor, that one simple sound is really just the first clue in a complex mystery. They have to know how to decode the cough. Right, because a cough is never just a cough. It's a clue. To get to the right diagnosis, a doctor has to look past the symptom itself and start piecing together the patient's unique story. How old are they? What are their other symptoms? What have they been up to? Every single detail is a piece of the puzzle. And nowhere is that story more critical than in the children's wing. When you're dealing with the youngest patients, these respiratory illnesses can go from bad to worse fast. So getting the diagnosis right and getting it right quickly is absolutely everything. So let's open our first case file. We've got a 6-month-old infant. The parents are, of course, really worried. You can see the baby is working hard just to breathe, and there's this weird sound with every single exhale. So what in the world is going on here?
Well, the clinical signs are pretty clear. We're hearing those wheezing sounds, and you can see those fast, shallow breaths. This is a classic textbook picture of bronchiolitis. Just think of it like an inflammation of the tiniest little airways in the lungs. You can imagine how that would make it incredibly difficult for a tiny baby to breathe. So what's causing it?
The culprit is respiratory syncytial virus, or RSV, as you've probably heard it called. This is the #1 cause of bronchiolitis in infants. And while, a lot of kids get it and are fine, for some, especially the really young ones, it can be incredibly serious. So by recognizing that pattern, the doctor has just solved our first case. Okay, so let's pop into the next room. Here we've got a toddler sitting on their parents' lap, and with every cough, there's a sound that is just impossible to miss. It's not a normal cough at all. It honestly sounds like a seal barking. And you know what? That sound tells us pretty much everything we need to know. That barking cough is the absolute hallmark of croup, which is an infection of the upper airway. And the virus that's usually behind it, that would be the parainfluenza virus. The cough itself basically gave away the answer. Case closed. All right, let's leave the pediatric unit for a bit and head over to the adult ward. The patients are different here, and so are the likely suspects. Now we're looking at community-acquired infections. These are the illnesses people pick up out in their daily lives, not in a hospital. So our next patient is an adult who's usually pretty healthy. Yesterday, they felt totally fine. But today, bam, a sudden high fever, chills, and this deep, productive cough. This is about as classic as it gets. And when a doctor sees this exact set of symptoms, one particular suspect immediately jumps to the very top of their list. We are talking about the single most common cause of pneumonia that you can catch just out and about in the world. And that suspect is Streptococcus pneumonia. This bacterium is, without a doubt, the king of community-acquired pneumonia. It's so common, in fact, that it's the very first thing doctors are going to think of in a case just like this one. But hold on, what about this next case? It's a little trickier. The patient had influenza. They actually seemed to be getting better, but then they took a really sharp turn for the worse. The fever's back, it's even higher than before, and that cough is severe. This is a really dangerous pattern. See, the flu does a lot more than just make you feel miserable. It can seriously weaken the lungs' natural defenses, basically opening the door for a secondary bacterial invasion. In these post-flu cases, doctors have to watch out for a particularly nasty bug, Staphylococcus aureus. It can cause a really severe, even life-threatening pneumonia. So far, our cases have been fairly classic, right? The signs pointed pretty clearly to the answer. But what happens when the symptoms are, just kind of weird? Welcome to the world of atypical pneumonia. In these cases, the clues are subtle, and the patient's history isn't just important, it's everything. This slide really breaks down the detective work here. Let's just compare two of these culprits. So first up, we have mycoplasma. The key clue here is that it starts out feeling a lot like the flu, but then it evolves into this nagging, dry cough that just will not go away. Now look at the one below it, Legionella. Here, a huge clue might be something in the patient's story, like were they recently staying in a hotel that has a big air conditioning system? Two totally different pathogens, two totally different stories. But both stories are what lead to the right diagnosis. Okay, finally, let's touch on a couple of special cases. These are the kinds of diagnoses that a doctor has to always keep in the back of their mind because missing them can have really serious consequences.
And this is a perfect illustration of one of the most famous ones. When a patient shows up with this classic triad of symptoms, a cough that just won't quit, night sweats so bad they're soaking the sheets, and weight loss they just can't explain, all signs point to one of history's most notorious bacteria, Mycobacterium tuberculosis. Let's do one last comparison. So on one hand, you have your typical pneumonia. It often has really obvious signs a doctor can actually hear in the chest with a stethoscope. But then you have something like pneumocystis jirovecii pneumonia. With this one, the chest can sound surprisingly clear. The main clue is often what we call exertional dyspnea. That means getting seriously out of breath from just a simple activity like walking up a flight of stairs. It's especially common in patients who are immunocompromised, maybe someone with HIV. Once again, the patient's context is the key. And that really brings us right back to our central theme for this whole thing. I mean, from RSV in a baby to tuberculosis in an adult, the specific bug changes, but the method doesn't. The presentation, that unique combination of symptoms, signs, and personal history, that is the key that unlocks it all. So the doctor's takeaway is really a four-step process. First, you have to listen to the patient's story. Second, you identify the pattern of their symptoms. Is it a barking cough or a productive one? Third, you have to consider the context. Is this a baby, an adult who just got over the flu, or someone who's immunocompromised? And finally, once you've done all that, you can pinpoint the likely pathogen and start the right treatment. You know, this same diagnostic story has been playing out in clinics for centuries. But with new tools like AI and new viruses always on the horizon, the next chapter is being written as we speak. The real question is, will we get better at listening to the stories our own bodies are trying to tell us?